So let's try to attack the last part of our today, which is the most beautiful one, I hope so. My wife always complains that I'm only talking to women. Look, the picture what I have. And when I talk to pharma companies, it's also all women. So, but it's a pleasure, yeah. So first I wanted to thank Dr. Haifa, but she came here, especially by plane, made a stop in Barcelona to come and visit us. Thank you very much. It's a great pleasure. It's used that in this event, we're always giving an award to people who is helping us to bring our family closer. We have been talking a lot about family these days, the MPN family. And the three of these professionals, they are a real example of helping us in bringing our work, which we're doing from patient to physicians and to pharmaceutical companies. And Laura, I think I remember we made the first MPN Spain we made at your hospital. And I think we had 30 people or something like that. And I'll never forget this first meeting which we had. The second we had in Madrid, and we had 3 patients. And we had four doctors and 3 patients, This is how it started these days. And Laura, she always, whenever we do something here in Spain or everywhere else, she's always helping us. She made a fantastic presentation once about the MPN in general, which everybody liked and which we show continuously for the patients, where you explain what is MPN. So, it's coming every year. We're bringing it in our websites, etc. No. With Natalia, I've also one thing very, very specific. Gemfin, if they have their national meeting, the yearly meeting, they normally invite me, and I can talk for 10 or 15 minutes there. And at the end of one of the talks, I said, well, but we were growing. We had now, these days, we had about 3,000 patients following in MPN Spain. And I said, I need help, because I get so many questions which I cannot answer. I'm not a doctor. I'm just a patient, and maybe more experienced than somebody else, but I'm not a doctor, and I need the cooperation of a doctor. So please, you were about 120 doctors in my room. And I said, please, who can spare some time for me? I would very much appreciate. And I said, I don't really need that, the president or vice president, has to offer himself. I know we're very busy, but I see so many young people here, and maybe, they can help us. Only one person came. She sits here. And since then, we have a very good cooperation. We can talk about everything, really. We also with Ingrid, she, on her special things, we had a lot of funny webinars, and which is, very, very much appreciated. Now, to find words about Haifa is very difficult, It's there are, for some people, words are not existing. You cannot say what you feel. We know also of each other for so many years, and I just wanted to thank you. It's really great, how you have. Without people like you, I would never have been able to do what we're doing here. I would never have been able to grow these organizations as big as we are today, and to come so close to pharma companies and to, in general, also to the physicians. We still have a lot of things to do, there's no question, but I think we have achieved tremendously. You're also many, many years in this business. I remember when I got diagnosed PV, which is now, my daughter corrects me always, it's about 35 years in the meantime. This was a black hole. It was just nothing was known. You had no real specialists, etc. So we have advanced a lot, and this is all basically, a lot of it is thanks to you. So I wanted to give a little memory for you today. I'm happy, it's just first one for you.
Thank you so much, thank you.
One second, I will. Natalia. And this is for you, yeah? Okay, yeah? Well, Marley. Still what es ist, ne? Okay, ja. Alles Gute. Vielen Dank, ja? Ja, vielen Dank, ja. So, that was a nice part. Now you have to do something for it, you know. See.
I was just talking with your wife, and I said that I remember that time that when you were starting, that the patient, he was a young patient, just diagnosed of PVRA, and that's right. Okay. And it was funny because he said,
Doesn't work.
okay.
It's
And
gonna
he
muy
was saying-
cerca. Muy cerca.
And he told me, this is very strange disease. I have never heard about this. Who can I talk with? Another patient. And I said, well, I know someone in El Hospital del Mar that is starting to get people together.
Yeah, yeah.
And so he started going with you, and from there we started that meeting
That's right.
with no coffee, and it was fine.
It was.
Fun
But different
meeting.
times. Absolutely,
Yes,
yeah.
with Blanca and Alberto.
Yeah.
Good.
No, it was
Funny.
good, yeah. Okay, so I would like to use the opportunity. See, I have to stand here apparently. I would like to use this opportunity that we have, 3 experts of MPN, but we're putting questions. I obviously have a few questions, as you can imagine, but about, I advised you that I will ask you is, I would like that you put some questions to one of the ladies. Not second opinions, but about real problems which we are facing, in our family, in our community. Does anybody want to bring up a question, or should I start to bring one up? Please.
Hello, can you hear me? Hi. Hi, thank you very much for what you guys are doing. Thank you, Peter, for the symposium. I just had a question because yesterday we learned that we should become active as MPN patients to reduce our symptoms. But then today we learned that, well, maybe we shouldn't be too active, like running ultra marathons and things like that. So I was wondering, is there anywhere, I guess it's a subjective question, but is there anywhere you draw the line between what you should do as being active?
Maybe I answer. I think, as you said, it is very important to be active, yeah. But I think it depends, it is individual. I always say an informed patient, this is the best guarantee for an optimal outcome. The point is, when I am informed, and you are not a begging person when you go to the physician. So when you ask, and you're not ashamed to ask, and even I think this is the beginning to be. On the other side, it is very important not to let the disease control your whole life. So, because if you are physically okay, but still the disease and am I doing everything right, it's completely day and night controlling you. It is a balance you have to find. And my experience is that most patients do find this balance, but active patients are really so important, at least in Germany.
Yeah. If I can just continue, I mean, we have seen a lot of information today. And I think at the end of the day, and I was talking with someone before on the break, you have to adapt to what is for you. We're not expecting someone that never has done exercise to run a marathon tomorrow. That's not the point. The point is what is good for you. And if you want to do little exercise, whatever is that, and I talk with Ingrid a lot about this, well, it could be yoga, it could be go for a walk, it could be running. It's fine as soon as it's on your balance and on your fitness balance. And the reason to do that is because what we want is improve your cardiovascular risk factors. What we want is to have a good heart. And it's not only with the exercise, it's with the diet, and it's with the mental health, because that's a big one here that has been on the well-being seminar that we have a minute ago. So it's as everything a balance. And I would also say okay to have a day that you are tired and not doing anything. That comes to your point. It's like you have to control the disease. The disease needs to be part of your life. The disease should not be manage your life. Is that tricking around and be like, you know what, I'm controlling you, and I'm doing this because I think it's beneficial for me. Running a marathon or running an ultra marathon, it requires a training. And it's the same that yoga. If I'm start doing yoga today, I'm going to have a lot of pain tomorrow because it's difficult.
And I don't like yoga.
And it may not work for me. And for me, what works is going for a walk, have a coffee with my friend, and then read a book or watch a film. But it's that balance that you have to have, isn't it? And it's really difficult. I mean, how you put down your normal life, I don't know, but it's that balance. But it's definitely, I mean, it's a benefit on that, but with the right amount, I would say.
Difficult to add anything else, but I think that you have to think that you don't have contraindication to do anything. You can do whatever you want. You have to find a way to get there, but you don't have any contraindication. Because sometimes I get asked, can I have a massage or whatever? Yes, you can do it. Your MPN does not contraindicate anything of that. You can do it, but you have to find a way to get there. Yes, it's the same as if you don't have an MPN and you want to run a marathon, you cannot do tomorrow. You have to get ready to that. The same with an MPN.
Yeah, I think with examples of patients, it makes things good. I have a patient with MPN, his quality of life, he defines it to have at least 20,000 kilometers bicycle per year. If he doesn't do this, then his life and his quality, it's a subjective, personal experience is very bad. And I had another lady, elderly lady, for her, the highest quality of life was her ability to have a walk around the house with her grandchild. And so everybody has to find what is good for me and what is right for me. And maybe finally an example, military person, a professional diver, these deep divers, he had PV, and you can imagine. But for him, this was his life, and his passion. And all the doctors there in the military, they said, not possible, which makes sense. And then he came for a second opinion. And I realized that this is his life, and it doesn't make sense if I control his blood counts. For him, it was this deep diving. So we discussed this a lot, and then he had super controlled values. We did that. And then I wrote him a paper that he can do this, and nothing happened. So, because, Sure. I realized it was so important for him, and nothing would have compensated this wish to be this professional diver.
John, why don't you tell a little bit of experience which you have with a journal? About the fatigue and not feeling good and exercising. What happened to you really when you went for skiing?
Yes, so what happened to me is that after a skiing holiday, I forced myself through my fatigue to do a lot of skiing every day from early to evening for 3 weeks in a row. And I was logging my well-being in our app. And then suddenly I noticed that my fatigue was really going down. And I then decided go back to my previous life. I have always been sportive, so changes to at least 4 times exercise a week. And now I'm symptom-free. And that took about 3 months. So that works for me. So I am absolutely agreeing. This is not a recipe for other people. And I try to convince people about this. You have to find it yourself. What works for you. I know exactly now what I need to do. I was not feeling that well yesterday, been on the spinning bike this morning, and I'm feeling great again. And it's, for me, it works that fast. You know, if I skip it a couple of times, fatigue comes back, and if I go back to my exercises, the fatigue disappears. Now, that's an easy way, and for me it works, and I'm sure that for a lot of other people, it will totally not work. So that is my experience.
Basically, we could say is that if you can continue your life with what you always have been liking to do, it's, you know, if you would just tell me now, to me, you cannot do anything. You have to sit home, read a book, and watch television. I think I will die in 2 weeks. You know, it will it will eat me up. But what I want to say is, if even that we have our MPN, we have to find a way to be happy, to overcome each problem what we have, and everybody has a different problem. We cannot put it as a general thing, but these examples, I think, show me very clear is that when you do something which occupies your life, you never will be in the danger that the illness is controlling your life, which is the worst which can happen to you.
And like, there is no magic pill for this.
No. Everybody has to find it. You know, everybody has to look for it. Whatever he likes to do, you have to keep on doing that. You know. And
Yes, maybe, and a tip, you know, it is a mental training, but everybody can learn this. I always say we don't worry that much about aging. We are getting older. We accept it. It's okay. And MPNs are also, thanks to the drugs, to the understanding, are a chronic thing. So just to get used, it is like aging. And I always tell the patients, you know, statistically, the probability that you will die or something terrible will happen with you is much higher whenever you go into your car and start driving. But none of us starts to think what will happen to me when I want to, you know, go into the car. So that's, I want to say, yeah, put it in context. If you know so much about it, you know what's good for you, then it's just like aging. Yeah.
Absolutely, yeah.
I'm not sure that's a comfort.
Well, yeah, I know, but we accept it, right?
Well, you would be surprised how many people cannot do it.
Yeah.
It's unfortunate, you know. I can see that I'm a lot in the groups, and I talk to many patients every day. And you wouldn't believe how many people simply says, I cannot do it because I have MPN. We're putting the border just on what they can do and what they cannot do on the MPN. There's people who totally changes their life. Some they have to, because, you know, they had a physical work and they cannot do it anymore. But, you know, there again, you have to work with on a fatigue, like John has been working or doing something else. But there's simply too many patients who are dominated by the illness.
But I think talking about it, it makes a difference, right? And I have conversations with a few of you. It's like, be able to talk about it and knowing what you need to look or how you need to approach that. Because obviously we're not expecting, you know, some people that do things because they can't do it because they have a knee operation recently. That's fair enough. But it's about how you confront those symptoms to be like, okay, let's change this. Yes, I'm tired, but let's find a way that I can change that. And there was a comment on about visualization, and that's something that athletics are using a lot. They visualize how they're going to win that 100 meters race that they're doing. And I think that is something that all of us, we can do. And you're doing when you prepare for a work presentation or things like that. You visualize you're going to do well there. So this is the kind of things that you can use in your daily life to be like, as Ingrid said, if you start your day saying, oh, it's going to be a bad day, well, yeah, of course it's going to be, because someone is going to, take your place in the tube, or you're going to be stuck in traffic. Yes, but maybe you can use that to read 10 minutes more of your book, or, reply that email that you didn't do yesterday night because you were watching something. It's how we can change the little things in a daily life.
I think you said something very important, to be able to speak about it. Sure. Yeah. Because this is a problem, many patients with MPN, and I see it all the time, the social, the family, the work, they don't understand because, you look so healthy and then you cannot do anything privately or you cannot do anything at work but if you start to talk about it and hopefully find, the community or the doctors that can understand you. I just give a very short example of a lady recently. Very nice lady, but she felt ET, uncontrolled. She felt very, very bad. And her daughter, she came from an area in Germany quite far away, and her daughter wanted to marry in August in Austria. But she was so tired, and she said, I will not be able to travel, and she was really feeling very sad. She had a very nice family, they understood. And I said, okay, and she was mutated, calretically mutated, and all the antibodies, the trials. I never screened somebody that fast. I told her, I promise that you will go to the marriage of your daughter. And we screened her within 9 days, bone marrow, MRIs, you never, and then pushed the company to give us. And then we only had the time for 2 infusions. They are given every 2 weeks. And after the second infusion, I now get goose skin. She was feeling so great. And she went and she sent me pictures. Her daughter wanted even to come 2 days prior to the marriage to thank us. I said, no, do it after the marriage. But, these are such great experiences. Sure. It's just, and her doctor always told her, that's it. That's the disease. You don't have treatment. And then she decided to come and seek another opinion. And, so I think this is the point. You have to find people that understand you. And I think the MPN advocates are a really good,
Sure. We have to. I think in Spain you have more problems to do that because you have little time for each patient, no?
Well, I think that is something that happens everywhere. It's not Spain only that
but
you don't have enough
here.
time. And what I was talking before with Gabriela is like, you can kind of get that time, but it's difficult to get the resources to resolve because, for example, I don't know, but doctors, we don't know a lot about, for example, social workers, things that how can you manage at work if they don't allow you to reduce hours. We don't know exactly how to resolve those problems. But once you start talking with the patient about that, you can kind of drive the question to the person that can resolve that. Mm-hmm. And so I think in Spain, one of the problems is probably there are the resources, but they are not in a network where you can use them for patients with chronic diseases. Maybe these networks work a lot for patients with acute leukemia, for example, or with other kind of neoplasms, but because MPNs is more like a diabetes, more than a neoplasm, is that they are in the middle. They cannot use these networks, for example, for a psycho-oncology, or they don't accept chronic patients. So I think it's our job from the patients' associations and from doctors to put these patients in this kind of networks because they need the support, especially with the problems at work, with the social problems they can have, or the psychological support, or maybe all these programs you were talking before about wellness, mm-hmm. That doesn't exist in the social security. And if you want to do it by yourself, you have to pay for that. And that's another problem. Sure. And I think that will help a lot.
Definitely, yeah.
May I ask something? Yeah. I would love to have a list of supplements. Which supplements are good? Which supplements are good when you are taking this medicine? Which supplements are good when you're taking another medicine? Like a matrix, Mm-hmm. Are flax seeds good for you? Magnesium? What kind of magnesium? Where can I read a trustworthy list of this? besides from ChatGPT, of course, which they say you should not trust it always. So, you know, I would love to have such a list.
I don't know if like if we don't have enough information. For example, all those supplemental medication, magnesium, there are no clinical trial that says if you have it, you feel better, and if you don't, you feel bad, and we have objective information about that. We don't. So that's why it's difficult to tell you if you have magnesium with I don't know what, or you will feel better. It doesn't really go that way. What if you have PVRA? It doesn't have to have iron, because that's a problem. But there is not very serious information that spending money on that will help you to feel better.
Maybe a tip, there are in the meantime really supplementary specialists in Germany at the University Jena. If you Google this, there is a professor for supplemental medicine, and I think you could write her these questions, because at least this is not, you know, Google or something. They are trying to do this supplemental stuff on scientific basis. And I think one could ask them, general for all patients. They have nothing else to do other than to look at all the selene, the magnesium, whatever supplemental medicine, herbal medicine. And yeah, at the University of Jena in Germany, I know that we invite them too, and you know, they give us real good tips.
Yeah, it would also good to know which ones can cause damage, are dangerous.
Well, a few we can tell that. As you said, iron is not good for PV. Yeah. We know that grapefruit, for example, is not good for patients taking Jakavi, for example. Yeah. These things we know. But
already two.
Selene.
Two. Already two.
And several marmalade for ruxolitinib as well.
Sorry?
But we don't have enough data. This is the problem. So we don't have data to say taking vitamin C, vitamin D, curcumin, turmeric is beneficial for MPN patients or for the general population. This is the problem. There's no a clinical trial. We will have the pharma here, so they can help to say if we take these supplements will help or not. We know vitamin D. I mean, obviously, except the ones that live in Spain, the rest of us we don't have much sun. We know vitamin D in general is good for the immune system. Will that be beneficial? Probably yes.
That's why the complementary medicine people, I think, could give good tips, because they, not specifically for PV, but for the general population, and so they might give, especially if you have something you want to do very harmful things. We know this, but you know, the other things
difficult.
Hello. No, yeah. How much do we know about the genetic transmission? Because I've heard, I mean, it's a mutation, etc. But lately, I don't know, I have been hearing a lot of people saying, oh yeah, I got it from my mother, I got it from an aunt, my grandma had it. And I don't know if it's just a big casualty or if there's more research to really know if I want to get pregnant in the future, if I have like a percentage of like, yeah, my children can get it, yes or no? Thank you.
We don't have enough data. I'm sorry, we're repeating here, but I know there is some investigations going on. I know the team from Adam Mead, professor in Oxford, they've been looking on families that we found just by casualty, but we don't have a clear link yet. I'll probably say that 10 years ago, I'll be more like, no, there is no any relation, 100%, or 99.9%. But I think we need to have more information. And I probably, I mean, let Professor talk, but I will not say at the moment there is a chance. We can't really say it, isn't it?
Yeah, very careful. There is no direct transmission, but definitely. So you can get pregnant, you can have a family, and I always advise not to make testing without symptoms because you destroy yourself. And we know in the population that, for example, 2% of the healthy population, they carry the JEC2 mutation. And the older you get, the more likely, up to 10% above the age of 70, they have the JEC2 mutation. And most of these people do not get sick. This is what we call CHIPs. So, and we always say the mutation calreticulin or CHIP or MPL is always one hit. And you always need another hit to get the disease. So there is no direct transmission, but there is familial predisposition. I myself have several families where 2 or 3 people, one has ET, one has PV. This is familial predisposition. This means, you have, I always say, you have something in your genetics which makes you susceptible to get the mutation, but it is not a direct transmission.
After my myelofibrosis, my AML, and my stem cell transplant, my father was diagnosed with PV. So we were all scared in my family. We talked with our doctor and both our kids. We said, well, we don't want to test it now because if now it's nothing, it can be more tomorrow. They can have a driver mutation. And we talked with the doctor and they said, if there are complaints like fatigue, then let the blood, CBC blood draw completely do, including platelets, and then you can figure out whether it's not MPN related. Yeah. And another thing, we're working with MPN journal, and we figured out that the amount of people that are saying that they are having family related MPN is 14%. So that's the data until now.
Yeah, it is familial predisposition in the, yeah. And, you can even, we send sometimes young people to genetic counseling, but you don't get a real answer why this family has, there is still more, but it is important to know that it is not infectious and that it is not a direct transmission.
Hi, I just had one more question. You guys talked about speaking up about your symptoms and being able to get help with the community and everything. I was just wondering about the awareness part of the speaking out about your conditions, because me personally, I come from a family background where everything should be like shoved down. They're like, just shove everything back in your closet and bury it deep, something like that. But I got to meet Peter's through Hoodie and Mari's Blood Club, and then I kind of just got inspired by them. And then recently I started my own Instagram account. By the way, a little shameless plug. You can find my journey through Instagram at Way of the Sword 222. Sorry about that. But I was just wanting to know, because my brain kind of understands the words, but my nervous system, I guess, doesn't get to register what actually awareness does to me, myself, and people like me who have MPN. So that's just my question.
This is a very, very, again, very, very personal. I know in many countries, many cultures, you don't talk about things. But again, I think talking, at least, you have to choose and decide to whom you talk. Whether you like to, there are people, they keep on, and it's not nice to keep on talking about diseases, Right. When you go to dinner and they just know that you are a doctor, everybody all the evening complains. I think this is not the right way. But again, the MPN community or a doctor or maybe a social worker or a psychologist, you have to decide what is the person or the persons I would like to talk to. But I think if we don't talk, we will not go forward, none of us. I understand you fully because, you know, I'm half Arabic and usually half German. And my personality is also not to keep on talking about things. But what I have realized over the years with the patients that, you know, you need to have somebody you trust. If it is your doctor, your son, your daughter, whatever, this is something you have to decide. And I know it's not always easy, but really, it helps. I think it helps.
I agree. Just one thing, Oscar. Yes. Just in between, you're on a trial, on a clinical trial. Could you explain a little bit, because I don't think that we know very much in Europe about this.
Hi, it's me again. I have.
What is your Instagram?
So I am on a drug trial in the U.S. It's methotrexate. I take 15 milligrams every Thursday for 24 p.m. I have the alarm on. I take it. I write it down. So my platelets are still around 1,000. It's not hasn't gone down tremendously, but my symptoms has mostly gone. So usually before the methotrexate, I used to have headaches, dizziness, fatigue, chest pain, just every suffering there is. But then right now, I feel like I'm almost to like 80 to 90% normal life, and just a little bit of high platelets. So yeah.
Do we have this clinical trial in Europe?
No.
No.
I've heard
I know I think it's only in the States probably, yeah.
As far, we don't have it in the UK. We tried to open it, but we didn't.
But it's more an inflammatory product, no? It's,
It is used it's a very, very old product. It is used mainly in rheumatology, but we also use it in ALL, in leukemias, in acute leukemias with very high doses. But in rheumatology, they use these very low weekly as an anti-inflammatory medicine.
I just wanted to add that I was told that it was used for other blood cancers, and they use it in like doses of like, I think 1,000 or 3,000.
Yeah.
But
And lymphoma.
But for me,
CNS lymphoma.
they're saying that it might be effective for ET, so they gave me like a 15 milligram dose every week. Yeah.
This is nothing, This is the rheumatology.
This
Okay.
is
This is a
a low
rheumatology dose.
Yeah.
Okay.
In other disease, we use in a really high dose and even intrathecals, I'm thinking CNS lymphoma, so really complex disease. So it's kind of half of the dose. obviously.
1%.
Yeah, yeah.
Thank you.
Is it worthwhile to do, to make it also here?
Yeah, in rheumatology, we use it even in young people.
No,
And-
for MPN.
I know. So why not in MPN? It is an anti-inflammatory. But to be honest, I'm not very much excited about that because, we have more and more better drugs. And at the end of the day, methotrexate is a chemotherapy. Although very, very low dose, it's okay. But, it's not my favorite number one.
Thank you.
Thank you.
That's not bad.
You had a question, no?
Hello. It's easier to, I guess, to open up to being that you're women doctors as well, and I'm sure you're familiar with, as a woman, going through ET, and I'm not 25 years old anymore, of course, so there's a lot of confusion I also get, let's say, between symptoms of aging, but also from the ET, so I wonder if you have some kind of guidelines on that. And secondly, I have heard that with ET or with an MPN, it's possible to get a secondary cancer. So for me, for example, it's important to go to different specialists and to talk to them about my MPN. And so far, they've been very open and curious about it. But just to have a preventative measure of having a secondary, I was wondering also your opinion on that, what you would advise as far as like going to other specialists, what kind of conversations I should be having. And also as a woman, as you know, there's the menopause as well. How can we somehow or other use maybe a guideline to help distinguish what are the actual symptoms of one thing or another?
Right, let me start there's two questions. My brain is going to different places, but Well, the women's situation, we did have a nice webinar talking about that and how difficult it is. Number one, because I was reading about this the other day, we don't have much information about perimenopause, a new thing, new diagnosis now. We do have information about menopause, but the difficulty is all of the symptoms that you can have, they can overlap with an MPN symptoms. And I was saying before to a person, you can't put on a box, today, my 20% of the fatigue is because my MPN, then my other 20% is because I'm going through the menopause, my other 20% is because I'm busy at work, and you can't really put it. So it's really difficult to make a line and say, this percentage is here or there. I guess one of the things is probably going to John and the team journal and is monitor that, because there will be symptoms that maybe at some point are more because of a menopause or perimenopause, whatever. But then it comes to going down to talk with your GP, your family doctor, or your hematologist, and doing like maybe some hormone tests and have that opinion for a gynecologist, because it's really difficult for us to be like, okay, this is the night sweats or the hot flashes are because I'm having MF or because I'm having menopause, right? Or because I'm in front of a public talking. It could be really difficult. But that's what I mentioned before. Just remember, just because you have an MPN, it doesn't mean you cannot break an ankle, right? And I'm putting an ankle for something silly and totally different. My point is like, think about all the problems, because as a woman, we're going to go through the menopause. Unfortunately, you can't take that away with MPN tablets. And it's important you are aware of that. And if you're thinking I may go through that, then you need to look for what's the diagnosis of menopause in someone that doesn't have MPN. Does that make sense? So I left my colleagues to talk, but that would be my thoughts. And then if they have to give you treatment, then that is the next question that needs to also have a conversation between the gynecologists or the GPs and the hematologists. We are allowed to give treatment to patients, and you can have it. You may need to have a lower dose to reduce the risk of a clot and a different type of treatment. But there's a lot of research as well on that.
There was a very interesting work that was performed it was done in the States by Dr. Mesa, and also in the UK with Dr. Harrison, that they give a questionnaire of symptoms, more than the MPM-10, it was like 20 symptoms, to the patient, and another questionnaire that the patient has to give to something close to the patient, but not living with them. So, cousin or whatever. And both on the symptoms, not knowing what the other said, and then they analyzed that. And it was really, really interesting to see that, for example, with MPN or without, they have problems to sleep, for example, or they were tired, or they have problem at work, or they have depression, or it was the same same symptoms and almost the same intensity, but MPNs had a little bit more. But exactly the same shape of, if you see, it was like a star drawing, and the peaks of the symptoms were exactly the same. MPNs a little bit more intense. So it's really difficult, if you read MPN-10s, to say this symptom is only because of your T or your P or MF. We don't really know, but we have to analyze how that symptom goes, if worse, or what gets that symptom better. That not always is the treatment you are doing. For example, on Thursday, I was talking with a patient that he had a total symptom score of 21, very stable. And last Thursday, he was like almost 14. What happened here? What happened? And I was thinking in my mind, well, I will have to push up the ruxolitinib dose. That was the only thing I was thinking about. And when you start talking, problems at family, problems at work, problems. So it's not that easy with a pill, with a treatment, with hormone therapy, or you have to be careful and analyze everything that goes on around. So it's not that easy to decide, this is from the MPN, so let's push up the ruxolitinib, for example, or whatever. Yes.
Yeah, and maybe a tip, work before I start with Rux or a medication. If, people have stress at work, I say, let's wait for the holiday and see what happens. This is very nice. This is a very nice tip. And I tell the people, please look at how you feel when you have all the stress away. And when the patients come back, then, some say, almost all symptoms disappeared. So, they are stress related and you don't need to do treatment. Sure, if they start again, then we start to discuss about how to make better, the work situation. Menopause, we have indeed many females, they have these problems, they discuss with their gynecologists, and the question always arises, should we give hormone therapy, with ETs? We are very careful, or PVs. Nevertheless, there are now very good drugs, progesterone, less estrogen, and we discuss it together with the gynecologist, or there are flusters, very nice things, and we do test them because, these therapies, making a holiday or having a fluster of hormone therapy, low dose, after discussing with your physician, will show the effect very rapidly. Our medications, and we start, and these are some tips we do. So it is always a try and error, And I always say it is so individual, and you have to keep on trying until you find the right thing for you. And this is really my challenge. So I can say, okay, with you, I have done the right thing. With the other, we still have to, try to find the right thing, yeah.
And also, I think it's important when we start, for example, a hormone therapy, or if it doesn't work, take it out quickly. Not keep there 6 months, hoping that it will work. No. You have to try to analyze very objectively which are the symptoms, why, or the problem, why you are starting a treatment, and if it doesn't work, take it out. Because if not, you start to accumulate different treatments, and that doesn't work.
You have the second question about the secondary cancer. So we go to quite similar thing as before. In general, any patient that have a cancer have more risk to have a secondary cancer because your genes are not perfect. Your genes has already made a slight mistake on the reading and make the mutation. So that is the standard thing. Now within MPN, there is a few cancers that are more common, and one of them is skin cancer. And I mean, in general, the population have more risk of having skin cancer. It's one of the most common ones. So in MPN, it's more common, and then if we add in some medication, then increase the risk. So I think the general advice is monitor and look for symptoms. So if you are, and also, I mean, I'm quite advocate to sun protection, even if when it's not sunny. And because most of us live indoors, then you just go out to the sun and stand there for like an hour or two, get totally red, totally burnt. That's not good for your skin, whatever you have a disease or not. So one is prevention, and prevention is always going to be better than cure. That's a standard. So I will recommend to all my patients use skin protection every single day. And most of the products now we have in the market, they have a skin protection already in like, I can't say the word in English, it's gone to my brain. SFP, all of them, all of the daily creams, they have it. So that's one way. And the other way is just monitor yourself. We'll do that with breast cancer, with prostate cancer. People get prevention, you don't really need to go and check. You're just doing the standard things you do for the general population. So just be more aware of, I will say, but I don't know if any.
Yeah, maybe skin, really skin. We know that even hydrea increases the risk of skin cancer. So we advise not ET patients, but PV, particularly PV patients have a very increased risk of getting skin cancer. Even without treatment, Professor Bezes has very nice work where he looked at PV patients before they started treatment, and he has shown that the patients have so many skin problems, pre-cancerous lesions. So skin, and the advice is generally to go to a dermatologist every 2 years. This is really important. And what is more important is, for example, again, mainly PV patients, if they had skin cancer, let's say because of hydrea, it is not a very good idea to put the patients on ruxolitinib, on Jakavi, because in this case, we know that the risk of getting another cancer will be 5-fold higher. And so it is always a very critical risk-benefit assessment in such cases. So the skin, otherwise, it is the usual prophylactic programs for breast, for GI, prostate for men, yeah.
And that's, I think it's a very important point, because when you start following your hematologist because you have a PV or whatever, some patients don't go anymore to the GP. And we need the GP there to control cardiovascular risk factors, and also to do the normal population screening for colon cancer. We need the gynecologist to do all the control for breast, for all the normal control. So it's important not to just stay on one chapter of your health, that is the MPN, if not to keep on the normal controls you will do.
Excuse me. In France, everywhere we say MPN are rare disease, but in my village we are 3 MPN. So I live in the countryside, and it's very beautiful. But we are 3, 2 ET and 1 PV. And I asked to the doctor why. He said, "Oh, I don't know. It's strange, but only it's strange. That's not an explication for me." And I ask if it's pesticide or we don't know. So do you have an explication?
Yes, I don't have an explanation for your village, but generally we know that MPN could be, from exposure to certain risks. We have several patients who work, for example, decades ago with benzol, for example, being painter, for example, or in the tire production. And this is really very important. We ask our patients what they did in their, if they always say we are retired. I say, you did not learn retired. It's really important to look, what did I work 30, 40 years ago? And if we have this suspicion, we send the patients to there are special doctors, at least in Germany, who will check if this is caused by work. And we have many, many MPN patients who are then accepted as cases due to work exposure. And, this doesn't make them healthy, but there is a lot of financial compensation because this is a work accident. So I think it is important to look what is the common thing.
The MF work was a German teacher.
So it is not likely to be the work,
yeah.
But again, then it will be much more difficult because, what
but
is in your area.
Yeah, we have a center for the fireman next.
Yeah, but this will be very complicated,
so,
who will prove it and how to prove it.
So it's difficult. And in France, it's very difficult to ask to some scientists to come and to make a study.
The same is true in Germany.
Yeah.
We do sometimes have this suspicion that there is accumulation of several cases from one area. And I know it's almost impossible, because nobody wants to know, to be honest.
It's better.
Yeah.
May I ask you a bit more difficult question? I'm becoming an expert in difficult questions. You know about this report from Susanne Isford about the behavior of patients and doctors. she checked, I think she had a group of 800 patients, and she was asking the patient the symptoms. How do you feel that, percentage-wise, how much does it influence your life? And I think she was everywhere between 65 and 75%. And then they asked the doctors who were treating her exactly the same question. And psst, please. And then the doctor said, well, it's 25 and 30%. So there is a very big discrepancy of how a physician is receiving, the symptoms of a patient, and very often not taking serious. Now, what I want to know is, basically from both sides, I would like to know it from you, same as from the patients. How can we improve the relation between patients and physicians in order that this gap will be less? There will always be a gap, because if you don't have something, you cannot feel how it is. This is normal. I think everybody will happen to that, But we should try to bring it down, maybe a 10, 15% difference, whatever. But what can we do in order that this huge difference of perception of the symptoms and how much is it influencing our life, but this can be reduced?
Maybe, 2 words to the work, because I was involved there too. We must be very careful because, they looked at what we documented. Patients fill the TSS, and the comparison, the physician were not asked, but they were looking at what we documented. And usually, I know myself, I don't document everything because, I have the TSS of the patient. So I think the discrepancy is there. It is getting better, but it is not that huge. And as we said in the beginning, it is your duty as a patient, not only as an advocacy to, strengthen the patients, but it's your duty to make physicians listen and realize what your problems is. And it is getting better, really. I still see catastrophes, but over the years, things are really improving.
And I think in that work, it was differentiated myelofibrosis, PBRA, and TE patients. The main discrepancy, the main difference was with ET and PBRA. In MF, we kind of
Come to agreement,
an agreement, and I think that the way to improve that communication is making an objective, kind of describing with numbers or putting numbers, because if you tell me you are tired, I will tell you I'm tired too. But if you are tired 10 out of 10 and I'm tired 2 out of 10, that's the point. That's what we have to talk about.
Yeah.
Well, I echo everything that we say here, and I think probably having the conversations we have in here will help. And we talk before about educating, and not everyone has the time or the experience that we have, right? This is more what we do on a daily basis, but it's about educating and bring to your consultants or whoever is seeing you, this is the symptoms, this is what is that. And it is difficult, to be honest, because I sometimes in the clinic don't have the physical time to document everything I talk with the patient. But, it's also about having a reflection, I guess. And the one thing we do in the UK is we do a feedback. We do a survey from patients and have a feedback, because the only way we can improve is if someone tells us we're not doing things correctly, right? In general. So I think it's really important having these open conversations.
I have a question, may I? To you all, really very important. We speak a lot about symptoms, and from ruxolitinib, Jakavi, the first phase 3 trial, they use this so-called TSS50, meaning a drug is only working if it reduces your symptoms by at least 50%. What is your opinion about this so-called TSS50? Because, in the last few months, 2 rather good combinations were killed by the authorities. One is not yet finally killed, but yeah. So because the drugs did not get this TSS 50, they showed that the spleens got better, the symptoms generally got better, and it was the fatigue which made this TSS 50 not statistically significant. And one combination has already disappeared, and the second is on the way to disappear. So the question from your point of view, TSS 50, is it for you only okay if your symptoms are reduced by 50%? Or would you say it is also okay 49%? I'm really interested.
When you look at the normal medication of MPN, when you look at the normal medication for MPN, it's only about preventing worse. So when you look then at symptom burden, like reducing 50%, that's the question, of course. The normal medication is already just, restricting, not getting worse and getting clots, etc. So I think there are two perspectives on this. Should it be reducing the symptoms, or should it be better in preventing getting things worse?
It is all from the authorities now. It is all patient-reported outcomes. This is very, very good. This is a nice change because the FDA and the EMA, they really look that it must be a patient-reported outcome to let a medication be approved.
We are looking at the treatment methods currently is preventing, and will it prevent better cannot be measured, I guess.
You can measure, you have the baseline before you start the medicine, and then you get the medicine, usually for 6 months, and then they look your TSS. In the initial, you had, let's say, 20 points. You have, after 6 months, to have 10 or less for the medication to be approved.
Looking at the risk of clots, etc., that kind of stuff.
They're not looking at this anymore.
But it should
They're
be.
only looking at this, and this is, we can just look at the opinions. It is dangerous because it is killing one drug after the other.
True, because we have interferon, but when you look at Pegasus versus Besremi, it's the same drug, in fact. But why is then Besremi approved over Pegasus?
Because it has a trial.
Yeah, it had a trial. Okay.
Pegasus,
Yeah, I have a very nuanced opinion on this because I think the benefit of this is that people designing a drug are not only looking at risk. They're not only looking at blood values. It's in our interest that this becomes part of the trial. And we're not just looking at the risk factors and the blood values, the lab results. So I think in that sense, it's a good development, and a development that forces pharmaceutical companies to take this into account when they do their trials. Because otherwise, they will not put this into the trial to enhance the probability of success. So in that sense, I think it's a good, a well-intended to get more emphasis on the symptom burden. But the result, like so many times, we are here, we want to improve it, and then we move here completely to the other side. And I think this is a case where we have completely moved to the other side, which is not in the interest of anybody, because it will create reluctancy with pharmaceutical companies to start the trial anyways, because if there is no immediate hypothetical improvement of symptoms, they might not even start a trial. And for us, it means that we will not get medications that could be useful for people who, for instance, are not responding on other types of medications.
I think it should always be patient-reported, but again, this fixation of the 50.
Yeah, I agree.
Because I always say the 50% is from, you know, a value. So it makes a difference if you have 40 points and you improve by 50%, you are still having 20 points. It is easy to reach this, and a medication should do this. But if you have only, let's say, 8 points, it is very difficult for a medication, which might be good for clotting, might do molecular remission, to have all the patients get down to below 4, you know? And this TSS 50, I say it should always be TSS. It should always be patient-reported. But the question is this TSS 50, because this is really hampering the development.
And how, like, as patients, how can we help you to communicate this? Because, for example, I didn't have any symptoms before, and now the symptoms I have are actually more from the treatment than from PV. So actually, this would make no sense in my case, and I know that in many young people, it's more like the concern is more focused on the progression, not that much on the symptoms. So yeah, if there's a way that we can support
No,
you.
but that's why I want to discuss this with you. I think, yeah, you have a big role, particularly with the agencies. And now the companies are really very worried. They are really thinking of not starting trials because of this TSS 50. So I think we are now in a process of learning. A drug must improve patient symptoms. Otherwise, it's not a real good drug. You know, it's not good for somebody to suffer, even if you have another benefit. It is quality of life. But the strict fixation of this 50 is making it so dangerous.
Especially because the drugs that are, I think we have to ask more, not just symptoms or spleen control. We need to ask something to change the disease, to stop the disease or to cure the disease. We have to ask for more all the time. And if a drug that is thought to be kind of a cure for the disease does not improve the symptoms, because we already have something else for the symptoms. So in these combinations, the objective was not only improve the symptoms. The objective of this was to reverse or at least stop or I hope cure the disease one day. But if we only, the authorities, the FDA or the EMA, only are focused only on these two objectives, spleen response and symptom response, we are not going to progress with this. And this combination that are in the edge, one is in the edge and the other one went backwards, that is something that worries because we need to ask more to the whole community. And the people that is taking this decision on only consider the TSS 50.
That's the number, yeah. This number, yeah.
And from the medical community, we are raising the voice to say, hey, we have to change this. We have better things now. We want more. And I think that from patient advocacy should be the same message. So maybe talking together, we can convince them to change this.
Can I ask a question? That 50%, is that an average over all the responses?
Right. Yeah.
So that is a stupid method of doing it, right? Because you would have some
I need you in
responders
the FDA.
who have a wonderful response and others have no response at all. So then you would have to say, well, you know, this is probably a medication which is good for some of the patients, but not good for others. So the rule, if you look at from a mathematical point of view, we'd have to look at the distribution, right? You'd have to say, well,
They
how does
look
it
at
work?
the average, and if the average is below TSS 50, that's it. Bye-bye.
The other thing about the patient-reported outcome is that it is also very subjective. I mean, obviously, some things you can, spleen size, you can measure, blood count, you can measure. But I always take the example when I have to fill in the questionnaire, I go to Professor Grieshammer in Minden, and I have to get up really early. And the question is, are you tired? And I think, oh my God, I'm really, really tired. And I'm biased at that minute, right? I'm saying probably I'm more tired than I would normally be because I had to get up really early to drive there. So it is twofold. The problem is really, the method is stupid, I'd say. So we should try and change that. But we also have to have a good mixture of things that we measure that are objective and subjective, and the subjective is always, a bias there.
But I can play the advocate devil here, but you have unfortunately to put a number sometimes. But I do agree, I think the 50% is ridiculous. It happened the same with the spleen side, isn't it? If it's not below 35, what is his 34.9? Then it's not responding. But following your comment about the symptoms, some of my patients are Monday clinic. So the question about the symptoms, I always asking them in terms of the fatigue. It's like, can you think about like before Monday? Because you're here 9 o'clock, probably driving, 2 hours, rushing in. No one's like Monday mornings. Of course, you're going to be tired. And I think that links really nice with the journal, because then you can actually put down more constant way, not only when you're going to see the doctor and start thinking, oh, how are my symptoms? No, it's probably better doing in a different days, because it's not the same when you come to see us or when you are at home, having a quiet day. It's probably, that's what I think is really important.
Yeah, but it is your duty. I always say this.
Yeah, 100%.
It is your duty to define what is important. And I personally, from a doctor's point of view, always say clinically significant, clinically meaningful. But the meaningful must be defined by the patient. The TSS 50 came in the ruxolitinib trials, and ruxolitinib was very good and it reduced, but now the authorities, are sticking to this. So I think it is the duty of the advocacies to define what is important, what is clinically meaningful. And then we have a voice and have to discuss with the EMA, because we physicians, they don't listen to us. The pharma, they don't listen to them at all. So, but it is a patient's perspective, what is clinically meaningful. And I think this is important.
Can we, as a patient organization, do we have a force in EMA?
Yeah. You know, the new, this so-called HTA, not UK, no, the EU, the reimbursement of medication that is approved is now becoming central for whole EU. And always, I am involved in the reimbursement process in Germany for several drugs, and patients' advocacies are always there. And now we have this European uniform reimbursement commission. You should be very, very loud and very, very clear, because I'm really worried. The countries are different. There are the countries where everything is available, and there are countries where less drugs are available, even if we are in the EU. And I am afraid that with this now central reimbursement commission, they will try to make medicine not available for all countries. And that's why the sound of patients is so important. And patients are always involved in these processes.
But mostly through authorities and these organizations who are not really patient organizations.
No, I think you can say something from Germany. You are asked, right, by the commission to be involved in the HTA, GBA. Yeah, you are asked always. Yeah. You don't say much, if I am honest. Yeah, but now it is changing to become European, and I don't know how they will ask, which, and this is very important that.
Well, I've been in Brussels about 3 weeks ago. One of the we organized a meeting with the politicians, yeah, all involved in the pharmaceutical thing. We had agreed meetings with 6 politicians from 6 different countries in order to discuss, but some little bit else, how dangerous it is to have only 1 or 2 products for an illness, yeah, which is another problem which we're having. But out of the 6 politicians, 1 came. The others, the same morning, they said, we're discussing the big package now, so I cannot. But there is one which is an ex-minister of health. He's from Lithuania, and we had him on streaming. And he's defending our position. He's very much in our favor. He actually invited me to a plenarian session in December. And I said, that's fine, but I want to talk. Just to go to listen, that doesn't make sense. So it's, I never wanted to be involved in politicians. I hate that. But, if it helps something, if I don't think we'll have now in December because it's, within short, but maybe in the next one, and we will definitely try to do something. And I didn't know that in Germany, they were asking them, I think, we, John, me, and, the others which are, Karin, which is available here, we should push the Germans to speak louder, or maybe that the Germans will talk on behalf of all the others also. So, it's not only the opinion from Germany, but it's also the opinion from Holland, Spain, etc., other countries together. I don't know if it's possible or not. Maybe I'm just fantasy talking. But, if we have an entry, I didn't know that. I didn't know that the German representative is invited there. In Spain, definitely not, and in other countries, I think also not. So, if we have that little hole where we can get in, okay, let's do it, let's use it. And, this is what you were explaining about this 50%, I think it's ridiculous. It's like when you say a PV patient, when he is 60, he's a high-risk patient. So with 59 and 364 days and 23 hours, he's not at one. But 1 hour later, it's becoming a high risk. It's about the same, crazy situation. So we have to fight against it, and I think this is something which is our responsibility. Yeah. And where we need also a cooperation from the patients, because, we will have to present documents signed. When we are fighting in Spain for the Bisremi. I have, signing collections, signature collections. I have over 3,500 signatures, which has been sent to the ministry, insisting we need Bisremi. It's like nothing, it doesn't help anything, but still, all these things can be done. And the more we do these things, the more we will have a chance to get something changed. I mean, it's what John said before, it's like a watch, a pendle of a watch, if you put them very much on the left side, woof, it goes very much on the right side. And this is what is happening today. And that's disastrous for everybody.
Been said before, but I'm on trial and I have to fill in a questionnaire every day, 7 questions. The first one is, how tired have you been today? And it goes from 0 to 10. In my case, it goes from 0 to 5. But when I put in 5, it's probably because I had a very bad day, a very bad night, or I had a lot of stress at work. It doesn't have anything to do, or not particularly has anything to do with the disease I'm coping with. So it's very difficult that you just fill in a number, and I understand it, but it's just a number and I can never give any context, which, well, they make a conclusion, but they skip my day-to-day life.
So you most likely will not reach the
No,
TSS
definitely.
50.
No, definitely.
Yeah,
Definitely.
This is exactly the problem,
Yes.
What is clinically meaningful?
Yes.
And we have all to work with this because, these authorities, they just, catch, you said, the pendle, and now it is on the other side, and we have to bring it back, we together.
But if you ask me,
But the authority, yeah, if they don't listen to you,
They don't, because
will
they only
only
look at my
the
numbers.
numbers. Yeah, they will only look at the numbers.
Yes.
Yeah.
If we do a lot of efforts to bring patients together from all over the world and try to find a way to give them opportunities to find other patients all over the world. We have also been trying to do the same thing for PAGs. My initial initiative was with MPNAN. And the second one was with Peter, where we opened up a section in MPN World for PAGs. Because the problem is that if we are here for a weekend and speak with each other, listening to you and suddenly realizing, oh my God, we have something to do here, and I wasn't even aware of it. We cannot, like Peter is saying, we try to find a whole. But if we want to speak with one voice, it has to be an orchestrated voice where we discuss on beforehand and take a common vision of what we think is responsible. But in order to achieve this, we need a platform for communication. If there is not an easy way to communicate between PAGs, we will never speak as one voice. So we are going to do an initiative to re-initiate this opportunity in MPN World, where we have a dedicated section for PAGs, which is currently not being used. There are only 40 people have registered there, and so
I'm not using it. I'm not using it.
And not using it, exactly. And
not using. Yeah.
And we should not blame them, because apparently there is no
PAG.
there is no added value for them. But I will talk with Peter and Ingrid and all the others of MPN World to find a way to have a new initiative and use this as a communication platform for PAGs, so we can have a central voice.
Yeah, I think, George, if you try to, as a European or even worldwide, to have a small article in a journal, just a short one, your sound, I think this will bring a lot without doing big studies or stuff like that. Just really a small article in a journal showing that for patients, just this rigid TSS50 is not clinically meaningful for patients. And that you need the voice of patients in these processes.
Consider it done.
Yeah, but it should be concentrated in all European countries.
I know.
We have to make it all. And then there's one important point, and we have Ulrike here. Will the German Deutsche Netzwerk, will they allow to cooperate with us in that question? Yeah? Okay, good.
Can you
That's what I wanted to hear.
Please? Can you include the UK? No, let's not alone. Come on.
Yeah, we have to forget politics. I think it is a common interest for everybody, for all the patients, because, drugs are being killed for this TSS50 average, It's never the one patient. So the one patient, I always say, that improved from 40 points to 21 points, he's still not perfect, but he doesn't count. And the one that reduced from, I always say, from 8 to 4, with 8 you don't have that many symptoms, but still he will count as a TSS50, which is just crazy, it doesn't make sense. The same.
Well, this is the same.
We are all in the same problem. The worldwide EMA and FDA are
they are the same, and whatever FDA, usually it's FDA, they start in, and then EMA will follow in. Because some of the drugs that are approved early in the States than in Europe. So it's just to have that unite voice, I guess.
Hello. I have some questions from the chat. that people are doing there. So the first one is, can MPNs become resistant to treatment over time? And is it possible to manage a disease as a chronic condition? I don't know if you understand the question.
Yeah, a simple answer, yes. MPNs are chronified. We spoke about this. It's like aging. Sure, resistance is always possible, but with the options we are now having, we are getting better and better. There's still some way to go, but it's good.
Thank you. And another one is, can splenic infarct occur in MPN patients?
Splenic, yes. They can. That's a way. You want to talk about it?
Talking about before is like, although MPNs are chronic diseases, with the treatment we have nowadays, we really cannot stop them. We improve a lot, we avoid a lot of complications that are the main problem with MPNs, but we don't stop them. It's like with the time, the drugs you start, it's like we have to find something else to treat them. That's why we haven't finished to study this, and we don't have to stop to getting new solutions for this. So it's a chronic disease, but we need to get more to stop them. We are only stopping complications. And regarding splenic infarction, it's a kind of thrombosis. And usually MPNs do thrombosis in not usual places. It's not you can have thrombosis in a leg, but also these infrequent places as the splenic circulation or the liver. Those are kind of places where if you get a thrombosis, you have to think in MPNs.
As we mentioned yesterday about Buchiari, that's the kind of presentations, and it's not uncommon to see those as first presentation in patients. And actually, sometimes it's even like 2 years. There were some Italian studies that saw the thrombotics event can appear 2 years before the diagnosis. So it's really important to just doing the JAK2.
There was a question. Yeah. No, yeah. But I think here. Yeah. Yeah. I think you had a question, right? Yeah.
Fortunately, there are pharmaceutical companies here in the audience also. I would like to hear from them their opinion about the TSS 15.
Are they gone?
So I will hand over the microphone. I'm sorry.
Yeah, thank you.
I
appreciate being put on the spot. Yeah, so I think Dr. Al-Ali makes a wonderful point, right? Especially with her example of someone reducing their symptoms from 8 to 4, and what was it, 40 to 21?
40 to
I mean, that's
21.
such a much more significant change, right? So it doesn't make sense to base it on a value that's been, when was it? When was that standardized? Back with Comfort?
Yeah.
Is that right?
Yeah.
It would seem only reasonable to have updated outcomes and primary outcomes specifically. So I agree with you. I think hearing your voice is something I asked for earlier. I think in the case of and Dr. Al-Ali, I'm from BMS, so it's nice to meet you. In our case, we kind of have looked at different outcomes for the treatment of MF, so we're not necessarily impacted by TSS. But certainly, I think, to see patient and trials progress, it would be wise to take all of your advice.
Sorry, I'm going to put you on the spot now. I'm just wondering, because we talk a lot about the symptoms, and yeah, we know they are really important, but I guess in some of the studies, we're also looking for other things, like cytokines, molecular response, thrombotic events, free survival, all of that. And I think that's the other point that probably the approvals is missing here. If we can demonstrate actually this drug, as we say, is reducing the molecular, then that probably will have an impact on the symptoms, because what you're doing is control the bottom line of the disease.
Sure.
Right? So that is what I think in pushing the pharmaceuticals to look also on that.
Yeah, but we have to get away from this TSS 50.
Exactly.
Because the
Forget about
most
the
beautiful
symptoms.
ideas,
Yeah.
you go, before you
Yeah.
start a trial, you have to go to these EMAs, FDAs, and have their okay. And the only thing they care about is the TSS 50. This is good as a patient-reported outcome, but it is now so rigid, and it is killing everything. And so nobody can start anything anymore.
I'll remain neutral on commenting on FDA, so I
Sorry.
don't want to get in trouble.
Not blame you for that.
They need to hear your voices. They need to hear physician voices. I think what industry has to say is probably much less important. And I think Dr. Al-Ali suggested that earlier. Thinking through the independence study, which we're waiting right now, right? They looked at transfusion independence. It's the first time in, higher risk MF patients that's been looked at. So I think that's an interesting and tangible outcome to look at. And of course, we can capture and qualify it in terms of improvement in quality of life as well. But yeah, I won't make any more comments about the regulatory bodies.
Sorry.
It's okay.
Well, we have a researcher here in the room. I would like to know, is that affecting your work already?
I don't know much of these cutoffs and all, but what I can say that I agree with IFA that so this is one thing that controls the efficacy of these drugs. I think we should really get rid of that. And also, as Natalia mentioned that we should really also consider other important aspects of the disease while determining the efficacy of a drug. So I share their opinion. So I don't have any further questions, comments. Thank you.
Yeah.
Thank you. Hi, I wanted to know if any of you have ever treated an MPN patient who experienced a complete molecular remission where their allele burden was almost undetectable, and what treatment goes. If that's the case, how does treatment proceed following that?
We continue. Because today with interferon alpha, over 3 to 5 years, you can expect at least 20 to 25% of patients to be reaching this molecular remission. The same is true for PV treated with ruxolitinib Jakavi. Again, after 3 years, you have in almost half of the patients a 50%, again we come to the 50% reduction, not in symptoms, but in the VAF, in the molecular remission. This is good, but today it is much too early to make any decision regarding the VAF. I give you an example. A young patient, he was low-risk PV. He was treated with interferon alpha. He had complete molecular remission. I stopped him not because of the molecular remission, but I had to stop him because he had liver toxicity. And his liver couldn't tolerate it. And I said, okay, he was low risk, so it is okay. Because we started treatment because of pruritus a few years ago. I stopped him, but then I followed him very carefully every 6 weeks to see what will happen. After 4 months, he had a full-blown polycythemia blood picture, hematocrit pruritus, and his VAF was only 2%. So what we learn, MPN is not just a VAF, it is much, much more complicated than just a mutation with an allele burden. So please don't just stick to this allele burden. There are so many other things, and we all have to learn before making other decisions. And we know, for example, in some cases, the JAK2 mutation is not the bad one, and if you push it down, you might give the chance to another mutation that was suppressed through the JAK2 to expand. we know that some cases of acute leukemia come from a cell that has no JAK2 mutation. So it is interesting. It is, I think, good to reduce the VAF, but today we should not make any treatment decision. It is still too early.
It is, I mean, we unfortunately we have to put numbers on how the reduction is, but I totally agree with you. And we are doing follow-up on the patients now to take that information. We have some data coming from the big UK study, the MAGIC, when we did that in a sequencing way, and we see a response, but it's still really early. And I will not give a holiday break to my patient just based on the JAK2 mutation levels, or the color even, or whatever other levels you're doing. Yeah, sorry, John.
Yeah, this brings me to another question regarding VAF and allele burden. There is some discussion going on for a couple of years already, and it seems like there is a little shift here. Should you regularly test for allele burden, yes or no? Does it make sense to have every 2 year, 4 year, a check, yes or no?
I will say yes, to learn, but the problem is that in most countries and most institutions, it is not reimbursed.
That's why I ask,
yeah.
because I was having this discussion with the regulatory committee in the Netherlands, and their response was, even if we have a VAF test, the outcome will not affect the therapy. And probably they are right, but my response was, having insight in the trend and the development might be informative in a later stage of your disease.
Right, and if we don't test, we will not learn.
Exactly,
you know?
yeah.
And that's why we are doing, I don't know, in the university it's a little bit easier, because if the insurances will come back to me, I'm not privately, I know they will kill me then, but that's why in universities we are doing this, but I know that in many areas we're not. We are doing it once yearly, because otherwise we will never learn. We will never learn, and we always make stupid answers, Yeah.
Thank you.
And talking about this, about the BAF, it's important to understand that it is a test. And a test, although it's negative, doesn't mean that the disease is not there. Because you can, it's the way how the sensibility, you have to see that. For example, if I use glasses and I take my glasses out, maybe I don't see an elephant. And if I put my glasses on, I can see it. So the way we test the BAF is the test we can see very, very little things, but we don't see all. So the fact that you have that test negative doesn't mean that the disease is not there. And on the other hand, if I perform this test in a lab and then I do it in a different lab, the technique is not exactly the same. And you can find that maybe in a lab you have a BAF of, 38, and in the other one you have 25. Both labs are working properly, but it's a variation of the technique. So in your individual case, if you perform, we do it once a year. And if I perform 1 year and is it 18, and the next year is 21, that patient is not worse. It's the same.
Yeah.
Yes.
So can I add technical note here?
Yes,
Sorry, Peter, I have it now.
point.
So there is a big discrepancy when you talk about WAF. So WAF is determined by taking peripheral blood, prepare DNA, and you subject them to sequencing, and then you measure whatever reads you get it. So as Dr. Ifa mentioned before, that patient on PEG interferon showed nice response, and then she stopped it. And when you measure from that patient peripheral blood, you get 0 or 1. So you said, okay, it's clear. But what happens that you have the cells which are seeds in the bone marrow, you don't measure them, right? And then we correlated in a study published in Blood a few years ago that in the bone marrow, you have still mutant cells. but you don't touch them, right? So you take the peripheral blood because it's easily accessible, you measure it, and you stop the treatment, and then your stem cells again start proliferate, and then within a few months you see them, right? So again, you measure WAF, maybe a few things. And then erythrocytes, if the PV patients, they lack the DNA. Erythrocytes lack the DNA. So you have to understand that. And then what you take the DNA is from lymphocytes and the monocytes, right? They're probably not the product that you are looking for. So those technical differences are often ignored in the clinics by doctors and then also during assessment. So we really have to consider that.
And maybe just one additional note. The issue with the VAF is exactly like the TSS50. What is the baseline? If you have 100%, a reduction of 25% means a reduction to 75. But what is the baseline? This is something that really drives me crazy. Because we always have in the trials and the data, 20% reduction. What is 20% coming from where? Is it the same if I start with 10 or is 100, So that's why I'm saying we still have to learn a lot.
We have to. And correlated with the symptoms, correlated with the treatment. It's not the same being on hydroxy for 10 years and then you move to ruxolitinib, then what happened? Or to PEG, what happened with the BAF? So it's a lot of learning on that. We're doing once a year at least. And we'll try to collect more information for that because it's open question yet.
But I think that although we don't have the answers, it's important for the patient not to worry about the BAF. Because sometimes why I found that because I do it once a year for patients with Rux or PEG, what happens is that if this does not get lower, patients start to be worried about, and this is going to take a long time together, and we cannot be worried about that. So I usually say, don't care about this. I look at it, but you don't care about it.
You see, I think that's the wrong answer for a patient. He
Yeah,
doesn't
I know
like
that
it,
it's not easy, but
I am probably one of a few who has an allele burden for over 20 years.
yes, because in the market we do it every year.
And it's not that it has influence on my life. I'm not worried about my allele burden. But when I look at it, it shows exactly the moments when I had to change from one medicine to another for any reasons. Because at the beginning, I only wanted to be with phlebotomies because that's the most natural. I don't want anything else. And then, slightly got a problem with spleen and other things, and you could see it on my allele burden. It went up, not very much, but I was normally 26, it went up to 34. That didn't worry me, but it's at 34. But I talked it over with Dr. Bisses, and he said, well, something is starting to change. I think we have to look at it. And when, after a certain time, when the spleen got grower, we decided that I had to go to hydroxy. Hydroxy brought it down again to 22 or 23. And it was basically the same for 12 years. And when my hydroxy didn't work anymore, and then it went up again to 35, 36. And then, we decided to take Yacavi, and now it's down to 12 or 16. But it is not something which worries me. And I think to most patients, BAF, doesn't worry them. What worries us is that there is a change, but we don't know how to interpret that change. This is worrying. Because for some reason, it's going up, and I found the reasons. So I think, I know it's a lot of different opinions, and I accept, all the opinions, But for me, it has been, very valuable to dispose of a allele burden curve for, I think it's 25 years.
According to Professor Grieshammer, there is also not necessarily a correlation between allele burden and symptoms, right? So you can have a very low allele burden, but you have bad symptoms, and you can have a very high burden, and you have hardly any symptoms. So I think it is nice to track, but the question is, what do you do with it in the end, right?
Well, this is exactly what I was going to say. The problem is we don't know. There is no clear correlation between, at the moment, BAF level, symptoms, thrombotic events, and it's not only if we reduce, what we do if we increase, and what is the percentage if we can say it's increasing by 20% or 10% is significant, or this is the where we have to go down to numbers and have more information.
Yeah. We have, for example, in CML, this log, very clear, defined logs. But here we speak always of 25, 50%, but we don't know what, because of the different numbers.
And we're talking about the JAK BCX, like only the JAK. If we go to the CALR or the MPL,
more complicated.
or what we're doing with the triple negative, do we, that even goes to, don't know how we're going to do that, but we'll go there at some point.
So I'm curiosity about the patients triple negative. What's your experience in the course of the disease? If you see any difference or where you see any difference?
Triple negative, you see mainly young patients?
Yeah, I am.
Yeah. It is, for me, older, I don't know how it's for you. For me, if I find an elderly patient with triple negative, I say, well, this is most likely not an MPN, but maybe mastocytosis or something like that. And it is very rarely to find a triple negative elderly, but young patients, up to 10% are triple negative.
And on my diagnosis, I have more than 4 million platelets.
Yeah, and the interesting thing that there are very nice works that sometimes we don't really know if triple negative are truly clonal diseases. There were some very nice work around 10 years ago that many of these young triple negative are actually polyclonal. I have several such persons. So I don't consider them as having a malignant disease. You get the thrombotic events, you have symptoms because you have these high platelets usually, and cytokines, but whether you are really a true myeloproliferative neoplasm has a big question mark. As I said, we have several such young ladies, typically young ladies. The prognosis is good, but you do have sometimes thrombotic events. But I have one with huge thrombotic events in the spleen, but now we have 2 babies together. Not together, but It's a lot of work I do to get the babies. So I always say they are mine. No, but So the question is it true MPN? Particularly, you don't have other mutations and nothing. So as I said, question mark.
Thank you.
But good.
Okay, I think we are over time. We should have finished at 6:30, 6:39. But I think we could talk another 2 hours, The 3 of you would be great.
Hello? Sorry, I just want to say something because I'm not going to be here tomorrow. So I want to say thank you to Peter, thank you to Ingrid, thank you so much. And also thank you to all of you because I'm taking a lot back home and it's really nice to meet you and have this opportunity. So I just want to say that.
Thank you very much.